Hello, my name is Peter. I'm from Scripps Clinic in San Diego. Happy to be here at RWCS. My title is Optic Neuritis and SLE. So my case is about reaching the correct diagnosis of optic neuritis, which is considered a MS spectrum disorder due to demyelinating and inflammatory process. Multiple sclerosis, lupus, and NF-hospital syndrome can be very hard to distinguish from each other, but it is crucial to find the correct diagnosis because treatment approach differs vastly. All three predominantly affect female in childbearing age, and there are increasing amounts of case reports due to NF-hospital syndrome cases misdiagnosis MS later improved with anticoagulation. So our patient is 32-year-old female with history of SLE and triple positive NF-hospital syndrome antibody status, who presented with 3-month history of blurred left eye vision. She works in insurance industry, and when she reads, she was skipping letters and color looked different, so she was making tons of calculation mistakes. SLE was diagnosed in 2012 with thrombocytopenia, malar rash, and she has been asymptomatic in the past 9 years on plaquenil monotherapy. History was notable for similar attack involving the opposite eye in 2017 that improved gradually, and then her eye symptom got worse after taking a hot shower. MRI showed numerous non-specific T2 signal abnormalities, including cerebral peduncle and cerebellar peduncle. Other lesions are thought to be artifacts, but these lesions are more significant. Autoimmune labs and MRIs often cannot distinguish between CNS lupus, multiple sclerosis, and anti-phospholipid syndrome. Our patient had high titer ANA, 1 to 640, but normal C3, C4, dsDNA, normal inflammation markers. She did have neuronal cell antibody, and also CSF showed oligoclonal band, elevated IgG, and myelin basic protein antibody. All of these can be seen in both multiple sclerosis and neuropsychiatric lupus. And as we know, all three diagnoses, lupus, MS, NF-hospital syndrome, they can have higher prevalence of NF-hospital syndrome antibodies, so they cannot distinguish between these three. And MRI of all three different entities can show non-specific MRI abnormality. So her history gave us the clue for the correct diagnosis. The fact that she had similar attack in 2017 suggested relapsing remitting nature of the demyelinating process. Also, she had auto phenomenon, which is that when she goes into the hot shower with core body elevation, her vision got worse and was reversible by core temperature cooling, which is a feature of MS patient. About 60 to 80% of MS patient has it. So she did not meet the strict McDonald criteria for MS diagnosis. However, we believe that she has MS spectrum disorder, and she's at high risk of developing MS in the next 5 years. Her vision improved gradually with solomedrol, followed by prednisone taper. We are monitoring her closely with serial MRI. In conclusion, we think she has optic neuritis due to demyelination process. Not all vision symptoms in lupus patient is due to lupus. And also, it is important to rule out anti-phospholipid syndrome if any MS patient present with atypical features such as headache or normal CSF. Thank you.